dedicated to empowering you with information
to make positive choices
and be advocates for your overall well-being.
Welcome to The Health View. Welcome to the second season of The Health View. I'm Yvonne Dunitz, and this is Dr. Matthew Stanizzi. Dr. Stanizzi is a urologist, and today our topic is going to be about prostate health. 1 in every 6 men are diagnosed with prostate cancer. And Dr. Stanizzi, we're so delighted to have you with us today. As a urologist, can you explain to people, first of all, what does a urologist do, and what is the training of a urologist, and kind of the gamut of what you see?
Okay, well, first of all, thanks for having me. As a urologist, we are tasked with dealing with diseases of the urinary system, specifically surgical diseases of the kidney and the rest of the urinary tract, the ureter, the bladder, etc., as well as the male reproductive system. So that kind of covers the places where the diseases we're going to be dealing with are involved. As far as training is concerned, obviously there's an undergraduate education, 4 years of medical school, and once you're done with medical school, there is an internship and residency program, which is an additional 5 years beyond that, part of which is a year or 2 of surgery, and then usually 4 years of specialty training in urology. Thereafter, you have the option of going into a fellowship if you have a specific area of interest that you want to specialize in. So that's the training, and it gives you sort of the skill set you need to be able to diagnose and then subsequently treat problems that people have with those parts of their body.
And what is the most common thing that you work with in your practice every day? Is there a particular component of diseases or symptoms that a urologist sees most of, or is it all of those things that you just mentioned?
I mean, certainly it's all of those things, but certainly in my practice, which is here in Nashua, New Hampshire, you have a tendency to see more things more often. So urinary symptoms, for instance, are very common. Pain with urination, frequent urination, that kind of thing. Recurrent urinary tract infections, kidney stones happen to be quite common in this area as well. And then the various malignancies of the urinary tract sort of come to our attention as well.
And so you see both men and women?
Indeed.
And do you also see children?
Yes, we do.
Okay, and the children, the types of things that come up related to them are also dealing with the bladder or different things like that?
I mean, with kids, it's more often related to infection or congenital abnormalities, malformation of their ureters, for instance. Young boys can have issues with the way the urethra forms or the testicles not being in the proper position, that kind of thing. And so those are things we're capable of addressing as well, or referring out to a pediatric specialist if need be.
Okay, so let's talk about prostate health. When we realize that 1 out of every 6 men are diagnosed with prostate cancer, the important statistic about that is that they don't automatically die of that, correct?
No, it's actually a readily treatable condition when people have it. The prostate cancer, I think, is kind of unique in the world of different cancers. And I always tell people, look, cancer is not a disease. Cancer is an adjective. There's a whole bunch of different diseases which the word cancer describes, and they all have different behaviors and different treatments, etc. Prostate cancer is unique in that it's a particularly slow-growing cancer for the most part. And so the likelihood of dying of prostate cancer is really low for 2 reasons. First of all, it's treatable, and we have effective treatments for it. The second thing is that oftentimes people get it as they get older. And so if you get prostate cancer, say, in your late 70s or early 80s, your life expectancy may be sufficiently short that you won't live long enough to die of prostate cancer. Whereas that same disease in someone who's, say, 50 years old may be a significant issue.
What are the symptoms that people should be aware of related to prostate health and prostate cancer?
It's an excellent question. I get this all the time. And so we typically say symptoms that might be related to prostate cancer are things like difficulty urinating, maybe blood in the urine, those kind of things. But the reality of the situation is that when prostate cancer is present and its curable state, which is to say confined to the prostate, it's usually asymptomatic. And that's the important thing, is that I have patients will come and see me and they're concerned because their stream is slowing down or they don't feel like they're emptying their bladder all the way, and then they're very concerned that they may have a prostate cancer. And I tell them, well, realistically speaking, those symptoms are way more likely to be the result of a prostate which is enlarging, which is a normal age-related change, as opposed to a cancer of the prostate, which, although can occur in the same place, is actually a different disease process.
So where is the prostate located in the body?
It's located at the opening of the bladder, and it's situated sort of between the bladder and the penis. And so when the urine travels from the bladder, it has to go through the middle of the prostate in order to exit the body. I can show you a
Please
diagram here that I have. This is the entirety of the urinary tract. Kidneys are up here. The ureters travel down to the bladder where the urine is stored. The urethra is where the urine travels as it's exiting the body, and the prostate is this small gland in between. So they actually kind of blew it up over here and kind of give you a three-dimensional picture of it, but you can see the urine tube actually travels right through the middle of that prostate. And so as the prostate enlarges with age, it has a tendency to create resistance so that the flow is obstructed, and that's what typically leads to men who are having difficulty emptying their bladder or urinating more frequently, those sort of things.
Now, are there certain types of things, like for women, like with prevention related to breast cancer? You do breast cancer screenings, and you do your own home exams related to taking care of you to see if there are any changes. Are there such things for men?
Well, there are, but they're not things that you can typically do at home, which is why it's important that you visit your doctor for assessment. The two things that I rely most heavily on are, one, a rectal examination, where you can feel the contour, at least of one portion of the prostate, seeing if it's smooth or whether there's nodules or hardness that don't seem like they should be there. The other thing that I think is more important is PSA. All right, PSA stands for prostate-specific antigen. It's a blood test and kind of gives you a look into prostate health. And if that number is not appropriate for the situation, it raises a red flag of maybe there's a prostate cancer. The reason why I think PSA is important is because early prostate cancer is not something that typically has symptoms, and because early prostate cancer is not something you might be able to feel on examination, we're then relying on another warning sign to tell us maybe there's a problem there, and that's where PSA comes into place.
Now, a lot of changes have been made related to recommendations for those tests now, correct? As far as how often they should be done? And who is doing the screenings? Like, should men be going to their internist or family doctor once a year to begin to be examined for this? Is it part of a normal exam?
It may not be part of a normal exam, and it's important to have a conversation with your primary care provider about whether or not you're appropriate to have a PSA done. The controversy about whether PSA actually is something that should be done came about several years ago when the U.S. Preventative Task Force came out with recommendations saying that we don't think the PSA is a good test. And people who treat cancer, whether it's oncologists or urologists, I think fought against that recommendation because it was based upon what I feel to be data which was inaccurate, not fully matured. I understand where the recommendation came from, but I think it's not doing the test at all is kind of throwing the baby out with the bathwater. The underlying argument is simply this: if you use PSA test as a routine screening for everybody, you're going to end up doing unnecessary tests, unnecessary biopsies, and possibly end up doing unnecessary treatments. All right? And so if you're looking at the population as a whole, which is what the U.S. Preventative Task Force is essentially doing, they're looking at and saying, look, what is it that makes sense to do for the population of the United States? And if you look at that, I can't disagree. Just blindly screening people for prostate cancer, blindly following up with a biopsy, and blindly treating prostate cancer will likely end up with you causing more harm than good. And so therefore, it may not be a good test. But as a practitioner, whether you're a primary care physician or if you're my patient and I'm treating you as a urologist, it's a different conversation we're having, because I'm not worried about the population. I'm worried about you as an individual. And for you as an individual, PSA screening may be appropriate. Essentially, I try to look at the whole patient. I look at their age, I look at their risk factors, I look at their life expectancy, other health problems. And I don't just look at one PSA. I look at how that PSA has changed over time. I look at some other parameters that you can use to sort of decide if that number is concerning. And then, based on that information, decide whether a biopsy is appropriate.
Is there a particular age that you would start to recommend for that test to occur?
The recommendations have changed. My general rule of thumb is around age 50, maybe to 55, depending on what recommendations you look at. PSA should then enter into the equation if a person has sufficient life expectancy. And we usually say around 10 or more years of reasonable life expectancy, that person should fall into a category where at least considering PSA is appropriate.
So let me ask, now we see in our culture that people are living longer. We have people living to their 80s, to their 90s, 100. And they used to say that if you've reached the age of 65 and you're healthy, that you probably have a good 15 to 20 more years, if not more. So when you say that, related to age 50, 55, when you're saying you determine the life expectancy, what do you mean by that?
I mean,
is it different for somebody who may have cancer of the prostate?
So it's not about them having cancer of the prostate and what does that do to their life expectancy. So for instance, I have a 55-year-old gentleman who has just had a heart attack, needs supplemental oxygen, or maybe has been diagnosed with some other disease. All right? That's a person who's not healthy. That's a person that's unlikely to live until they're 80 or 90, in which case screening them for prostate cancer may not be doing them a lot of good. And in fact, you may be getting information which raises concern, where there's really no substantial risk to that individual. Okay? Whereas you take a person who's, say, 75 years old, but he's still running 3 or 4 miles a day and just completed the Boston Marathon, that's someone that, although is older, and you might think maybe I shouldn't check the PSA based on this person's age, they're a really, really healthy 75-year-old. And that's someone I might consider checking the PSA on, because if they do get prostate cancer and they're destined to live another 10, 20 years, a significant prostate cancer at 75 will impact that life expectancy. And so, again, you have to individualize it. And what I tell patients is that if you are going to your primary care physician and they're saying, well, we just don't check PSA anymore because it's not a good test, what is essentially happening in that conversation is we believe that checking the PSA is more likely to lead to tests and other problems, and we're trying to avoid those things for you. The drawback is that in doing so, you may have a treatable prostate cancer that is destined to kill you, but we're not going to discover it because we're trying to avoid those other things. And I think one of the problems in the argument of should we screen or should we not screen, often you get this, grouping together of screening and biopsy with the potential drawbacks of treatment. And treatment is not the same thing as screening. Whether you move on to treatment is a different argument between whether or not you should diagnose the disease.
So it's an important thing to do, and it sounds like, are you seeing patients based upon referrals from the family doctor and the internist?
Yeah.
And is there a communication related to them, related to what they should be looking for regarding patients and perhaps prostate screening and good health?
It depends on your institution. The institution where I'm employed, we all kind of got together. We actually had a working group with some of the primary care physicians and us as urologists, and we sat down and said, okay, look, there's a bunch of recommendations out here. Let's, as an organization, come up with reasonable screening guidelines based on our clinical knowledge, what's out there in the literature, et cetera. All right? And I think that was very helpful because I think the primary care physicians, who are usually primarily responsible for doing the initial screening, have been a lot more savvy in figuring out who should be screened and who shouldn't be screened. Now, there's other organizations where that conversation hasn't taken place, and the screening may not even be happening at all. And if I'm seeing patients from a different organization where that isn't happening, I might be seeing maybe a 55 or 60-year-old male who has a kidney stone, for instance, and I'm looking through, I'm like, they've never been screened for prostate cancer. And so then I'm offering that initial screening, not because they were sent to me for that, but a separate and unrelated urologic problem.
So let's break it down. What are the types of screenings that are done?
Again, it goes back to those two things. The screenings are usually constitutes a rectal examination
Yeah.
and a PSA.
Okay.
All right, those are the primary two tools that we have in our toolbox. There's other ones out there, but they don't surpass PSA and the exam of the prostate as your primary assessments.
And BPH?
BPH is a separate and distinct thing. Okay, so BPH is not something that requires screening because we know that as a person gets older, their prostate is going to get larger. That's what BPH is. It's benign prostatic hyperplasia. All right, BPH and prostate cancer are two distinct and different diseases that happen to occur in the same place.
Okay.
There's overlap with symptoms potentially. There's even overlap with the screening tests that you do. All right, so that, for instance, an enlarging prostate may cause the PSA to go up, but so can prostate cancer. So one of the things that becomes a little bit tricky and is a little bit more of the sort of art of being a urologist rather than the hard science is being able to look at all those things in context and make an accurate assessment about whether or not you're concerned for prostate cancer. I always tell men, look, if you're a guy, you have testosterone, your prostate's going to get bigger. All right, and the enlarging prostate may lead to symptoms. Why? All right, prostate is a gland of reproduction. Right, God put it there because it's part of the reproductive fluids that are necessary. Right? And the prostate begins to grow when you go through puberty. Right? So so you go through puberty, your testosterone goes up, you get the male characteristics of a deepening voice, facial hair, what have you, but internally things are going on with the reproductive organs, one of which is the prostate beginning to mature so that it can do its reproductive function. Now, unlike women, men don't go through menopause, which means the prostate is always under the influence of testosterone, which means the prostate's always going to grow, and it's going to continue to grow with time. For some men, the prostate will grow to the point that it begins to block the flow of urine and lead to those symptoms.
Okay.
Right? And as again, separate and distinct issue, within that prostate, which is likely growing, you can also develop cancer cells.
That's a good distinction to make. So now let's make a distinction about the treatments.
Okay.
Are they different?
Oh, absolutely.
So let's talk about it. Let's
Okay.
go back to the PSA and talk about treatments related to that.
So we can first talk about an enlarging prostate
Okay,
and what
let's
we
do
do
it.
for those urinary symptoms, and
Perfect.
then go into what do we do about prostate
And
cancer.
do you have anything to show related to that?
I mean, it's more of the same. So I don't actually. I think the
one we showed before.
one we
is
showed before I
helpful.
think is sufficient. I mean,
Okay.
just as long as you remember that there's a gland there that's going to sit in the way of the flow of urine.
Okay.
So if we take for a moment that every male is going to have an enlarging prostate to some degree with time.
As a normal process of aging.
Normal process of aging.
Okay.
All right. And most men will notice first maybe a slowing of the urinary stream.
Okay.
All right. Maybe it takes a little bit more time for them to empty their bladder. Maybe they don't feel like they empty to completion. Maybe they have to strain a little bit to urinate, or the stream starts and stops. Those are normal, we call obstructive symptoms. The
Okay.
prostate's getting in the way, the urine can't flow quite as well. Now, for most men, that may be a little bit of a nuisance, but usually doesn't prompt concern. Often, over time, because the bladder's working harder to empty, the bladder begins to get a little unstable. And then you may find yourself urinating more frequently. You find you maybe have to you don't get much warning when it's time to go and you run into the bathroom, okay? And those are what we call irritative symptoms. And those are the symptoms that usually bring a patient in for treatment. Not always, but often. So then the treatments we have for that collection of symptoms are aimed at reducing the obstruction. 20 or 30, probably 20 or 30 years ago, 30 or 40 years ago, we had, there were surgical options. There's still surgical options now, but over the last 20 or some odd years, there have been some very effective medical treatments that allow us to treat that. The first class of medications relax the muscle within the prostate, because the prostate is a gland wrapped up with muscle. The point of that muscle is to squeeze the gland during sexual activity.
Right.
All right? But if when you're not engaged in sexual activity, you're trying to loosen up the tissue so that the urine can flow through more easily, you can hit that tissue with medications that relax a smooth muscle. Therefore, the resistance to flow is decreased, the flow increases, the bladder relaxes, isn't working with so much
Over time,
irritation,
yeah.
and the flow is improved. All right, so that's one type of medication. The other type of medication actually directly affects the size of the prostate. It works on a hormonal level. So you actually block one of the testosterone ingredients, if you will, that causes the prostate to grow. That same one we talked about at puberty that causes the prostate to grow initially, you can selectively block that hormone production, which causes the prostate to shrink. By decreasing its size, flow is also increased. All right, so those are the ways you can deal typically medically with the prostate becoming larger. If that doesn't work, or you have a patient that's resistant to taking medications long term as kind of a maintenance, there are surgical options, right? Different ones out there. I think the ones that work the best, that are time tested, are all aimed at removing the obstructing tissue.
And what are they? What types of procedures?
They're usually what we call cystoscopic, so you're putting a telescope into the bladder.
And is that a painful thing?
It's usually done under anesthesia, so
Okay.
it can be painful if you did it while you're awake. When someone's asleep, they're not feeling anything at all. When they wake up, it's often more of an irritation that they may have in that part of their body, because we're not making any cuts.
No,
We're
what are
using the
you
holes
doing?
that God gave us.
Yep, and you're going through that to be able to see what?
To look at the inside portion of the prostate. So if I now use this here, and we zoom in, this is kind of an example of a prostate becoming large over time. All right, this would be the urethra coming down this way, and the bladder would sit up this way. Now, it's like in the prostate to an orange. There's a skin and there's a pulp.
Yes.
Right, and you can see the pulp here is beginning to grow. That's what causes the blockage of the urine tube. So if you put a telescope into the prostate and use some type of mechanism to scrape this area out, you're actually expanding the urine channel by
Opening it up.
removing the obstructing tissue.
Uh-huh.
And that will result in better flow. My preferred method is something called a TURP.
What does that stand for?
Transurethral resection of the prostate.
And
Okay.
what happens then? What do you do?
So the telescope goes into this area.
Okay.
At the end of the telescope is a wire loop. It almost looks like the back end of a paper clip.
Okay.
All right. Through that loop, electricity can be run, which then heats up the loop, which then allows you to essentially whittle out the inside portion of the prostate. Channels open up, urine can flow more easily, and the symptoms are relieved. There's variations of that theme. You can use a laser to have a similar effect, and there's other surgeries where you may use the laser to sort of core out tissue, and different sort of options in that front. But again, almost all of these effective treatments are aimed at reducing the amount of tissue that's blocking the channel.
And enabling everything to flow smoothly.
Correct.
Okay. And those, again, are done in the office procedure-wise or in the hospital?
Most of these procedures are going to be done in the hospital under anesthesia.
Okay. And does a person end up staying overnight, or do they leave in the same day?
So my practice is typically to keep a patient overnight and send them home either the day or the day following. There's some things you have to look at that may not make it safe for a person to go home. Are they urinating? Should you take the catheter out? Should you let them try to urinate on their own? And that's a little bit of a moving target and patient specific. But in general, it's going to be a 1, maybe 2-night hospital stay with at least an attempt to allow the person to urinate on their own following the procedure.
And then what are the things that they do after that to stay healthy and well and not have this problem come back?
I always say that prostate healthy is in general heart healthy, so I don't have any usual specific recommendations like eat this particular vegetable or take this particular vitamin. It doesn't really work that way. But overall, living a healthier lifestyle seems to support prostate health. Some of my colleagues will recommend taking that medication that shrinks the prostate with the idea that, look, you scrape all this area out, that's great, but what's to prevent the tissue from continuing to grow? And the answer is there isn't. That tissue will continue to grow. And for some men, say 10, 15 years after their initial treatment, they may become obstructed once more because the prostate has regrown. And there's some medications you can use to prevent that from happening, but I typically tell patients one of the benefits of having these surgeries is to not have to take the medication. And if it gets to the point where the tissue is regrown and we need to address it again in the future, we'll cross that bridge when we get to it.
Are there problems with the medication in the shrinking?
Look, every medication has side effects, but in general, if you don't need to take a medication, there's cost and expense to taking medication long term. When we're talking long term, it's the rest of your life. So don't take a medication that you really don't need unless there's a reason to do so.
And so it's conceivable that once somebody has this particular treatment, they can go on for the rest of their lives not having a problem?
That's the plan.
And do you oversee them every certain amount of time to follow-up visits or anything of that sort? Or unless they have symptoms, they're okay?
I think in the first year or two following surgery, I usually keep an eye on these patients. But at a certain point, they may be stable. Their urinary symptoms are under control. They're not having bleeding or infection. I'm not worried about any potential consequences or complications from the procedure, like scar tissue developing, for
Right.
instance. And they're doing great. And that's a point where I may say, look, you don't need to see me on a regular basis. Continue to follow up with your primary care physician. You can come back to see me if and when there's a problem.
Very good.
I do also tell those patients that if you've had this procedure to relieve the obstruction, it doesn't mean that you can't get prostate cancer.
Okay.
And that's an important thing for them to know, that even though the prostate has been worked on, we've been dealing with the benign enlarging of the prostate, not the potential risk for prostate cancer. And I have had patients that have done this procedure on the TURP, and then several years later, they've come back to the office with a PSA, which has been rising, and then after that, I've diagnosed a prostate cancer.
So let's switch now to the prostate cancer. And so before we do that, would there be certain symptoms that you tell people to watch for with the knowledge that, in fact, that may be a possibility in the future or not?
I mean, look, I tell patients that if there's any change in your urinary symptoms that you find concerning, let me know.
Okay.
Because just because a new symptom is developed, it doesn't automatically mean that there's a prostate cancer there. They could
Exactly.
have, again, regrowth of the prostate. They could have scarring. Heck, they could just develop overactive bladder. I mean, so there's other things that can cause urinary symptoms. In fact, one of the difficulties, I think, with urology in general is just about every urologic problem that you can think of often presents with only a handful of symptoms. And being able to pick out what your particular problem is, we're often relying on things like blood work and imaging studies such as ultrasound to really try to hone in on, okay, what's the reason that you're having this symptom versus what's the reason that other person's having the same symptom.
Have we missed anything related to the enlarged prostate at all?
I think those are the pertinent things to talk about
Excellent.
for now. We've talked about the medications, the surgical intervention, and the point is that's to some degree an expected change over time.
Okay.
Okay?
So now let's move to prostate cancer.
Okay.
All right then. So start with symptoms, treatment, screenings, start.
Okay. So again, symptoms, I usually think of prostate cancer at its early curable stage as a silent cancer. All right, most men who are walking around diagnosed with prostate cancer in its curable state don't know they have it. I have family members that have fallen into that range, and most of my patients fall into that range. Rare is the person who comes in and it is prostate cancer that's causing their symptoms.
Really?
All right, if it's more advanced, right, and I do get these patients that don't see their doctors, don't get regular checkups, maybe they haven't seen a physician in years, if ever,
Yeah.
and they're coming in because they have difficulty urinating. And at that point, you see all those potential symptoms you see with an enlarging prostate, but now when you examine them, they don't have this large prostate, but they have a prostate that feels hard and nodular and blatantly abnormal. And now you're thinking, okay, yeah, these are all the symptoms of BPH, but the way this prostate feels, I'm very concerned about the prostate cancer. All right, and in those situations, the PSA test is usually is significantly elevated, much more than you would see in somebody who has an asymptomatic or prostate cancer. Okay, so for the most people that are coming into my office, it's either myself or a primary care physician has checked the PSA. The PSA has been hopefully rechecked, and we're seeing a trend in that number that isn't natural for their age, their state of health, or what have you. And if that happens, I will make the recommendation to move on to the diagnostic test.
And
right?
what are those?
That's the prostate biopsy.
Okay, and what is a biopsy?
Biopsy is removing a small piece of tissue from the organ in question, examining that tissue under a microscope, and seeing if the tissue has cancer cells in it.
And that's a surgical procedure that's done in a hospital.
The biopsy, most of the time, can be done in the office.
Excellent.
Okay, so it doesn't require general anesthesia. There are some exceptions to that rule, but the vast majority of patients that I perform biopsies on, it's done in my office while the patient is awake, and they're able to tolerate it with some discomfort. I never tell people it's going to be a painless procedure, but I also say it's unlikely to be painful.
Okay, that's good to know. And then from there, once you do that biopsy, the biopsy you're looking for is the specific result if they have cancer or not.
Correct, but you may want to hear what the biopsy entails.
Please.
All right, because I think it's important for people to hear what it is, because
Yes, it is.
at first, if I explain it to a patient, it sounds a little scary.
Okay.
And I think the reality of the situation, even though it sounds scary, it's usually not as bad as it sounds.
Okay.
And I tell patients that we perform the biopsy similar to the way that I perform the exam of the prostate, and that's through the rectum. Okay. Except at this point, instead of me using a finger to feel what the prostate, see if it's hard or what have you, we're putting an ultrasound probe into the rectum. That allows us to do a number of things. We can look at the prostate, look for areas that are suspicious, put some anesthesia in there, which is important. And then after we get that information, we then use the ultrasound to guide a needle into selected areas, basically sampling different spots of the prostate. Okay. Procedure takes about 5 minutes. I tell the patients that there's a risk of bleeding. In fact, it's not really a risk. We expect there to be blood in the urine, blood in the stool, and blood in the ejaculate. Those usually resolve with time without much to do. A bigger risk is infection, right? Because we're biopsying through the rectal wall. It means the needle's passing through the rectum into the prostate and back out multiple times. Not surprisingly, you can introduce bacteria into the urinary tract, causing a urinary tract infection, or into the bloodstream, potentially leading to a blood infection, which can be serious. Fortunately, those infections only occur about 1 or 2% of the time. They're serious and potentially life-threatening when they do occur, but being aware of the possibility allows us to be proactive in treating, and we usually give antibiotics both before and after the procedure to prevent that from happening. But it is a substantial risk, and it's one of those sort of concerns that I think prompted the U.S. Preventative Task Force to say, are we really doing right by our population by recommending PSA if there's going to be a bunch of people getting this biopsy and they really don't need it?
So the substantial risk, is it because of what you're putting into it or the back and forth related to any infection that can occur? What is the big risk about it from the information that you're trying to obtain?
The risk is in the process of getting the tissue from the prostate, extracting the tissue, you may introduce bacteria that naturally live in the rectum into the bloodstream.
I just wanted to make that clear. That's what I thought, but I wanted to make it clear for the listening audience.
And usually what happens is, unbeknownst to us, there's a bacteria that's living in that area that's resistant to the bacteria, to the antibiotic which we provided. All right. So, and I tell all my patients that that's a risk. However, if you look at the statistics, right? So the risk of getting an infection that winds you up in the hospital is about 1 in 100, maybe 2 in 100. But the risk of having an underlying prostate cancer, by the time I've made the decision that it's time for a biopsy, is at least 50-50 or better. So you look at the risk versus the benefit, and in my mind, the benefit of detecting a prostate cancer that may be life-threatening and may foreshorten your life expectancy is worth the risk when you look at the risk of ending up in the hospital for a few days because maybe you end up with an infection. All right. Again, I'm sure there's someone out there who just got a biopsy, got the infection got the best of them, but I've never seen it. I'm sure it's been reported, but ultimately the risk is there, but the risk is small compared to the benefit of detecting a prostate cancer that needs to be treated.
Okay.
Okay.
So now let's talk about treatment. Have we covered everything related to your screening related to that and the tests that you do, or have we missed anything?
I think there's other things that we may incorporate into screening.
Let's talk about it.
Sometimes we'll just follow the PSA over time.
Okay.
Maybe we're not ready to pull the trigger on doing a biopsy.
Okay.
But at the same time, I'm sufficiently concerned that just going to routine screening I don't think is appropriate. There's different ways of looking at the PSA. For people that have high cholesterol, there's good cholesterol and bad cholesterol. There's a similar thing that you can do with PSA. So is your good PSA versus bad PSA ratio in your favor or not? MRIs are now incorporated, I think, into screening, looking for suspicious areas. Sometimes doing an MRI that you fuse with the ultrasound picture so you can direct biopsy areas to, direct the biopsy needles to the area of highest concern, are other ways of trying to scrutinize the tissue and make an accurate diagnosis. There's some other blood tests out there, something called PCA3, which is utilized by a lot of my colleagues. I don't rely on that so heavily myself, but there are other ways of looking, trying to ultimately say, look, are we concerned enough that we need to be doing a biopsy, or are we reassured? One of the things that I sometimes will do is that medicine that shrinks the prostate should cause the prostate number, the PSA, to go down by about 50%. So sometimes if I'm not sure the prostate's big, maybe they have some urinary symptoms, I'll say, look, let's start you on this medication and let's see what happens to the PSA. Because if the PSA goes down appropriately, I'm reassured. Whereas if the PSA doesn't, that's another red flag. All right? That's an off-label use of the medication, but I find that maneuver to be helpful in some patients.
All right.
All right. And I think the most important thing for people to hear is there's actually not a lot of risk to the patient by delaying the biopsy in several months or more, because prostate cancer is slow growing. And there are plenty of times I have patients that come in with a falsely elevated PSA. Okay, I'm like, I don't know about this. Let's just recheck the number, see what it does, and we recheck that number again 3 to 4 months later, and the PSAs come right back down to normal range. All right. So again, it's not blindly biopsying because a PSA is elevated. It's being smart about the number, looking at the patient, giving it a little bit of time, not biopsying based on a single PSA unless you have really good reason to do so. And in that way, you can often avoid unnecessary biopsies just by being smart about how you use the test. Now, why might it be falsely elevated, you might ask, right?
I was just going to ask.
Right? The prostate may be enlarged. You could have an infection in your urinary tract. You could have something called prostatitis, which is an inflammation of the prostate, sometimes related to bacteria or not. Sometimes we don't know. Sexual activity around the time of a PSA check may cause it to rise. I had a patient that was training for a marathon, and the question was raised, do you think the stress on my body from training from the marathon caused my PSA to go up? I'm like, I don't know, but I don't think it's going to hurt you if we wait till you're done training and then recheck the number, and the number would come down again. So, so my motto is never biopsy on a single PSA, because you're probably going to be over biopsying your patient population.
And especially when you said because it is slow growing, so there's not the urgency. So you have that little window of time in between to make sure that the numbers are in fact accurate, so that the next step is what you really need to do.
Yep. That's correct. I'm trying to also train some of my, or try to help some of my colleagues by, they'll often ask me, oh, I have this patient with this PSA has gone up. Should I send them to you? I'm like, well, just check the PSA again in another 4 months. If it's still elevated, send them my way. Because guess what? Unless there's an obvious, problem when you examine the prostate, that's all I'm going to do anyway. Check it again, and then make a decision based on a follow-up number, confirming the value being abnormal before you go and put a patient through a test that has risk.
Okay.
Okay.
So now we've covered all the tests.
I think that's the lion's share of the stuff you have to know about PSA screening and biopsying.
Okay. How about treatment?
All right. So then the next question is, what happens if you detect a prostate cancer? And this is the next kind of wrinkle in prostate cancer treatment that I don't think the U.S. Preventative Task Force covered. And that's, not every prostate cancer that you detect needs to be treated. Okay? So there's a couple of reasons why treatment may not be necessary. Number one, the person has sufficient health problems that they're unlikely to live long enough to die of their disease. Right? And that's someone you might say, look, we found a prostate cancer here, but we're going to keep an eye on it because I'm really worried about your heart health. Or maybe the person was diagnosed with a different type of cancer, something that's way more dangerous and moves a lot more quickly than prostate cancer. You may diagnose a prostate cancer that maybe it's too late to treat, someone that maybe delayed too much time, and by the time you've identified the disease, you can't cure it. So you're not going to try to cure something that you have definitive evidence is uncurable. All right. Fortunately, I don't see that often. And then this is the one that I think has become more popular over the last decade, and that's what we call active surveillance. And this is the idea that not everybody who has prostate cancer in their gland is that prostate cancer going to grow, which is kind of a weird thing in the world of cancer. Like, hey, you have cancer, but we don't have to worry about it. We don't have to treat it right now. All right. Why do we believe this? Because if you look at autopsy studies, people in their 20s and 30s that were killed in, say, automobile accidents, and if you look at their prostates on autopsy studies, there's a detectable amount of prostate cancer present as early as 20 or 30 years old.
Really?
Okay. Now, which is unusual, because if you think that cancer is going to behave like other cancers, that means you should be having that same percentage of the population coming in with advanced prostate cancer 10 or 15 years later, and it doesn't happen. Right?
What if there's history in a family of prostate cancer? Does that make it different?
I mean, it certainly makes a difference, but what I'm talking about is a cancer which is extremely small in terms of the amount that's there, and the cancer doesn't appear aggressive on the microscope, because those are diseases that may not grow. Said another way, it's cancer cells that are perhaps hibernating, cancer cells that are requiring some other trigger, perhaps something in the environment, something in our diet, we don't really know, that then causes those cells to turn on. And the question is, if those cells never turn on, do you really need treatment? Can we watch carefully holding back on definitive treatment until such time as it's clear that this cancer is progressing. All right? And the reason why you might want to do that is because the treatments we have, the definitive treatments for curing prostate cancer, have some pretty substantial side effects, and people may want to avoid those.
Okay.
Going back to your point, the decision about whether or not we take that next step to go to cure or whether we kind of carefully observe,
Right.
family history is one of those bits of information we may use to make that decision.
Okay. So now in treatment.
Okay, so now if you're moving on to definitive treatments, I would
Yes.
say in general, the two time-tested things that we know can cure prostate cancer when localized to the prostate are radiation and surgery.
Okay.
Okay, each one of those have a sort of, different variations of that theme.
Yes.
Okay. Radiation is not something I typically do myself. I will often refer a patient to a radiation oncologist, and they're a different type of doctor who have special training and learning how to apply the right amount of radiation to specific areas of the body, destroying the cancer cells without hurting surrounding tissue whenever possible.
Now, is that where seeds come into place?
It's one type of it. So a brachytherapy is what we call that, and that's where instead of having an external radiation source which is aimed into the body, instead of doing that, you're actually taking radioactive pellets and surgically implanting them into the gland, into the prostate.
And how is that different in the end result for the patient?
I mean, typically speaking, in terms of the dose delivered and the potential side effects, they're very comparable. If you look at the data, higher or more advanced diseases may not do as well with seed implantation alone. And over time, seed implantation has become less and less popular for two reasons. First of all, the people that were great candidates for seed placement are now equally good candidates for perhaps surveillance.
Now, why is that?
Well, so in those patients that have very low volume disease,
Okay.
right? So there's not maybe a detect in one spot, 5% of that area
Yes.
was involved.
Yeah.
And you look at it under the microscope, it's not aggressive. That's the kind of disease that I said may not actually be in a position where it's going to grow.
Okay.
Well, guess what? Doesn't matter what you do to that person, they're going to be cured, right?
The body's going to heal itself.
Not necessarily. If you did nothing, the patient would never have the disease progress.
Okay.
So if you took those patients and you did treatments on them, of course you're going to have excellent cure rates on those patients because there's a percentage of those patients that didn't even need treatment. Okay, so whereas you have a more aggressive disease, the radiation dosing needs to be a little bit more powerful. And one of the problems with seed implantation is that you're specifically placing the seeds so as to give a lower dose of radiation to the sensitive areas surrounding the prostate. The urethra, which as we talked about runs through the middle.
Yes.
The bladder, which is next to it. The nerves that are responsible for generating erection run right next to the prostate. The rectum itself, which sits underneath the prostate, and the sphincter muscle, which is the muscle valve that keeps the urine in place, are all right next to the prostate. And so when you're implanting the seeds, you're trying to create an area where less radiation is going to be delivered to those areas because you don't want to damage the healthy tissue right next to the prostate. Well, what happens if you have cancer right in those areas? You may be undertreating the cancer. So in general, because of those limitations of safely doing a seed implant, you may be unintentionally underdosing some disease that may be there, but you're unaware of it. Whereas the external beam radiation kind of covers a larger area. And as a result, I think is a little bit more effective when you're trying to get a bigger dose to a larger area, encapsulating or treating more of the tissue that you think may be involved in the cancer.
Any side effects from either of those two methods of radiation treatment?
Yes.
What would they be?
So initially during the procedure, during the radiation treatment, people will describe maybe some tiredness, some irritation in the urinary tract or in the bladder. Those typically resolve within several weeks, maybe a few months after the treatment. But I always tell people radiation treatment is something that damages the cancer so the cancer cells die. That's good. But the radiation will also damage the healthy tissue surrounding the area. And that radiation damage to the healthy tissue never goes away.
So what does one have to do
Well,
to
if-
help that?
There's nothing you can do to help that. Once you make the decision to have radiation treatment, you're accepting the long-term risks of radiation damage to the healthy tissues. And that can result in things like bleeding in the bladder. It can result in bleeding from the rectum. It can result in damage to the nerves that control erection, resulting in erectile dysfunction. It can damage the muscle that controls continence, so you can get leakage. And so, and as time goes on, those problems have a tendency to accumulate. And so you see someone that's 2 or 3 years out from radiation, they may be doing very well. You take a patient that's 20 years out from radiation, and they may have scar tissue in their urinary tract or problematic bleeding from their bladder. Right? Which is why one of the things that I try to use to help decide whether or not radiation versus surgery is appropriate for a patient is how old is that person? Because someone who's got 30 years to live ahead of them, a 30-year life expectancy minus the cancer, that's someone I'm a little bit nervous about doing radiation. Whereas if someone has 10 or 15 years ahead of them minus the prostate cancer, radiation may be more appropriate because I'm really not worried about the long-term effects of radiation 20 or 30 years down the road.
Okay, so now we've covered the area of radiation as a treatment, the 2 types of radiation treatment, and now surgical treatment. What are the surgical treatments available for people?
Well, the surgical treatment is pretty straightforward. It's removal of the entire prostate gland. Okay. So you're within the surgical suite. You're separating the prostate from the bladder. You're separating the prostate from the urethra, and you're removing the prostate as well as 2 glands that are associated with it called the seminal vesicles, which I believe I can show on this model here. So, again, this is representative of the bladder. As you can see, kidneys up here and ureters going down here. Prostate, again, is very much part of the bladder opening. On the back side here, there's 2 glands. These glands are called the seminal vesicles, and they also supply some of the fluid that is present in the ejaculate. So we have to make incisions here, separating the prostate from the bladder.
So you could use the pen, actually, to show the areas of where you would do that.
Okay, so remember also there is a sphincter muscle here, that's the muscle valve that controls urination, and then downstream of that is the urethra that travels through the penis.
Okay.
So again, very simply stated, you are separating the prostate from the bladder in this location.
Okay.
You're separating the prostate from the penis in this location,
Okay.
and then also separating the prostate from all the surrounding structures, the rectum, which lies underneath it, and then you're separating the seminal vesicles here. As a result, you have a gap between the bladder and the urethra that needs to be brought back together again using sutures.
Okay.
In addition, the nerve supply that controls erections runs right alongside the prostate here, and those delicate nerves need to be separated from the prostate to try to preserve them if possible, because that's one of the things that helps men recover sexual function following surgery.
So it's an intricate.
It is.
Yeah. And are there particular tools that you use? I mean, so much has been advancing in the surgical field. Is there anything that you use to be able to access that better now?
Myself and a number of my colleagues are now using something called the robot. It's a very advanced piece of laparoscopic equipment, and that helps facilitate doing that procedure in a less invasive fashion. Which is in context with the open surgery where an incision would be made from just below someone's belly button to the top of the pubic bone. You'd separate the abdominal wall and be able to visualize the prostate with your eyes and hands-on. Okay? I think both are good techniques, and there are still some excellent surgeons out there who can do really, really fantastic open surgery. I recently had one of my patients go down to New York with one of the people that I trained with, who had an open surgery done there, and it had an excellent result. I think a lot of people like the idea of minimally invasive, and this robot that we have allows very fine movement of the surgical instruments through very small incisions to be able to accomplish the same feat, but through small openings.
Is there a specific additional training for that?
There are some urologists that will go and will seek specific training and a fellowship for that. I was fortunate where I got to train with some really quality exceptionally skilled laparoscopic surgeons. And then when I went into practice afterwards, I had the opportunity to practice those skills with some of my other colleagues before I set out doing it on my own. All right, so you can do a fellowship, and that will give you additional training, or you can seek out that additional training on your own after you finish with a standard residency. And I was always very cognizant of my own skill set, and I didn't set out on doing this on my own until I was confident that I could accomplish the procedure safely and effectively for my patients.
Okay.
I think the robot's been a great advance in terms of doing minimally invasive surgery, and you know, the removal of the prostate using the robot, I think, is probably the key example of how that technology has made laparoscopic surgery something that a large amount of urologists can accomplish. Because doing that same procedure without the robot is extremely difficult. And I was fortunate where I got to actually see some of my colleagues when I was in training do that same procedure without the use of the robot, which is very difficult. Right. The robot itself doesn't make it a better cancer control surgery. I don't know that it really has a significant impact on the risk of urinary incontinence following the procedure. I don't know that that the laparoscopic surgery is going to have improved sexual function after the surgery. Right? Those are all things where if you have a good open surgery and you have a good laparoscopic surgery, the result of cancer control, urinary control, and return of sexual function, those things are going to be comparable. But where the robot often provides a major role is decreased pain, faster recovery. The catheter that's left inside the urinary tract following the procedure comes out often earlier. And almost without debate, blood loss during the procedure is reduced by doing the laparoscopic versus the open surgery.
Very interesting. So now we have just covered all of the components of treatment for prostate cancer.
Those are the treatments for localized prostate cancer when you're dealing with the disease which is still felt to be in a curable state. There's a few permutations of that. Lymph node dissection during the surgery is something that's sometimes accomplished. I don't think we should spend a whole lot of time on that. Okay. That's a conversation that people can have with their treating provider if a diagnosis of prostate cancer is made. But again, those are the major treatments for localized prostate cancer, which is not the same thing as what happens if local treatment fails. And right. Despite our best efforts to treat the cancer, it spreads.
Okay.
Or if someone, by the time they come in and see us for the first time, already has prostate cancer that's spread.
Okay. And so what happens with the spreading? And what does one do? What's the outcome there?
Well, I usually tell patients once the prostate cancer is spread, it's not curable. Doesn't mean it's not treatable, but it's not curable.
Okay.
Fortunately, we've kind of had a renaissance over the last, say, 5 to 10 years of a whole bunch of new treatments that have come out in this specific type of disease, the metastatic prostate cancer disease process. They're all aimed at sort of tweaking hormones. I don't know if again, we're going back to that hormone discussion, the prostate growing as a result of puberty, different ways of manipulating the hormones to get the prostate to shrink. Well, in a similar way, we know that prostate cancer is fueled by testosterone.
Right.
And so the initial treatments when prostate cancer is spread from its initial location into other parts of the body is either to do nothing initially, but at a certain point when we realize that treatment is going to become necessary, is to provide a medication which will actually cause the testosterone level to go to very, very low levels. Right. That can be accomplished. In the United States, we usually use injections that basically tell the brain to turn off the on signal to the testicles. Okay. Testosterone level goes down, and the prostate cancer will go into remission for a time. On average, that remission lasts about 2 years. And at a certain point after the fact, the prostate cancer will begin to figure out how to grow, even though the testosterone level is very, very low. Right? And that's the place where some of these new treatments have really come into play. Again, further manipulating the testosterone, the reaction of the testosterone to the cells to sort of keep the prostate cancer at bay, which has allowed us to manage even metastatic prostate cancer for many, many years, upwards of maybe a decade or more. So even if you have prostate cancer and you fail local therapy, and it comes and spreads, you're still looking at a life expectancy of upwards of a decade or more because of these medications and the things we can do to control cancer even when it's gone to other locations.
So many advances in medicine to be able to allow that to happen.
Correct.
From a prevention point of view, if we could just look at what are the things that men should be doing from a preventive point of view to help them have healthy prostate?
All right. Again, not much you can do about the growing of prostate over time.
Okay.
But prostate cancer development and the risk of prostate cancer seems to be tied into those things that also affect cardiac health. And so if you look at, and there's been a number of studies looking at pomegranate juice, looking at selenium, looking at different vitamins and supplements, looking for something, like the magic bullet that makes prostate cancer less likely. And those studies almost always don't show that it's one particular thing that you should be doing. However, when taken as a whole, its overall heart-healthy lifestyle lends itself to a prostate-healthy life, a prostate-healthy lifestyle.
So let's summarize what the most important heart-healthy things are for people to do.
Okay. Diet.
Correct.
Right? So you want to
Good
make sure
healthy food.
good healthy food, whole foods, things that are not going to be processed.
Exactly.
All right. So that's important. Exercise, right? 30 minutes,
Every
3
day.
or 4. Every day is nice. I try to be a little bit realistic. I think at least several times a week, exercising for 30 minutes, getting your heart rate up. You know, and you don't have to be at the, the gym pumping iron or running on a treadmill for an hour. It's just being active, increasing your metabolism, increasing your calorie burn, so that overall your caloric intake is offset by, or the food that you're taking in is offset by the exercise that you're doing. What does that lend itself to? Less weight. You're not going to be obese. That lends itself to being heart healthy.
Exactly.
Which then in turn affects things like cholesterol, high blood pressure, risk of diabetes.
Exactly.
Right? Because those are the risk factors. But those risk factors, especially nowadays in the United States, hinge upon healthier lifestyle. All right? And so all those things are heart healthy and will decrease the risk of prostate cancer development.
Excellent. Plus, obviously, also getting good fluid in, water, right? Drinking plenty of water. How does that relate to a urologist's point of view?
I often feel like you have to drink X amount of water per day is
to stay hydrated.
Is important, but I think maybe overstated. It certainly doesn't, I don't think, has a direct effect on prostate health. All right, but I think it definitely has effect on the development of kidney stones. And I tell my kidney stone formers, you need to be drinking 2 liters, 64 ounces of water a day to try to offset that risk.
Very important.
But fluid intake does another thing, which goes back to the cardiac health. If you drink a lot of water, but your stomach is full. If your stomach is full, you're eating less. And if you're eating less, you're having less calories. Less calories means less body fat, and less body fat then leads to all those other things we talked about.
Excellent. You have done such an amazing job of covering this whole topic in a way that I think that our audience will greatly appreciate it. And I very much appreciate your being here today. The more that we can do to educate and raise awareness for people, the better it is, because our goal on this whole show is to provide the best information we can so that people can make excellent, positive choices. Till next time, have a great day.
Thanks for having me.
Thank you.
The preceding program